Hello, today we're going to be presenting Reducing Catheter-Associated Urinary Tract Infections, a Quality Improvement Initiative. I'm Mariah Rodriguez.
I'm Veronica Orellana.
And I'm Allison White.
So a bit of background about catheter-associated urinary tract infections, or CAUTI, is that they are one of the most common healthcare-associated infections in the US, and little to no information is known about prevention and the epidemiology of pediatric CAUTIs. 65 to 70% of CAUTIs are considered preventable. CAUTI patients are also at risk of developing meningitis, bacteremia, and pyelonephritis. CAUTI has also been associated with poor hospital outcomes, including increased length of stay, high hospital costs, and even death. Some causes and risk factors are prolonged use of urinary catheter, irregular cleaning, poor aseptic technique upon insertion, and failure to empty drainage bag promptly. CAUTIs are the third most frequent cause of pediatric healthcare-associated infections and has only recently become a real recognized issue.
Intervention. The Institutional Review Board at the Children's Hospital of Philadelphia reviewed and approved this study. For observational study number 1, data range from July 2009 to June 2012. An observational analysis was conducted on a 500-bed tertiary care children's hospital. They assessed changes in infection rates before and after a multidisciplinary QI project to reduce the rate of pediatric CAUTI. For observational study number 2, data range from July 2009 to June 2012 as well. A retrospective cohort study was conducted at the hospital. They conducted a house-wide surveillance for CAUTI with the use of National Healthcare Safety Network definitions for symptomatic urinary tract infections, and it included patients under 18 years of age.
So key people and organizations involved. The Prevent CAUTI QI plan featured a leadership team consisting of stakeholders, and in order to create rapid change, the team met weekly and created a driver diagram, set goals, developed and implemented an education plan, monitored progress, and addressed any identified or perceived barriers to success. The Prevent CAUTI team also, along with the Children's Hospital of Philadelphia Simulation Education Center, created an intensive education module for all clinicians in areas with the highest rates of urinary catheter placement and/or utilization. And this included ICUs, an oncology unit, emergency departments, operating and radiology suites in order to accompany the institution-wide rollout of the CAUTI bundle.
Some procedures for CAUTI prevention include minimizing exposure to devices by inserting catheters only when necessary, and also having daily reviews of catheter necessity and prompt removal. Another procedure is evidence-based practices of catheter insertion with hand hygiene, aseptic technique, appropriate catheter size, allowing povidone iodine to dry completely, and inserting catheters to the Y purification. Another procedure is having communication and transparency by developing reporting systems for units, and also CAUTI rates and compliance with key process measures shared hospital-wide, and also having collaborative meetings with unit-based teams. Another procedure is infrastructure support with financial support for new equipment needed for insertion training. Another procedure is compliance with basic standards of urinary catheter care, which includes standard precautions, hand hygiene, daily care of indwelling catheters, and maintaining an unobstructed urine flow. And lastly, another procedure is educating and training of staff and family.
Outcome and process measures. The primary outcome measure was the monthly hospital-wide CAUTI rate per 1,000 catheter days. The goal was to reduce CAUTI rate by 50% in 1 year. A process measure is the review of catheter necessity at the time of insertion and for every day of use with the goal that under 95% of indwelling catheters would meet under one indication or indications defined by the bundle. It included monthly unit-specific and hospital-wide compliance reports that were used at unit-specific QI meetings. They designed PDSA cycles to facilitate and measure daily assessment of catheter necessity. There was daily monitoring of catheter necessity. They trained unit champions to discuss necessity of indwelling catheters with the patient care team. And unit charge nurses assess daily all patients on their unit for presence of and an indication for a urinary catheter to determine compliance with the key bundle measure.
Data collection methods. So the study team used records from the Children's Hospital of Philadelphia Department of Infection Prevention and Control to identify all CODIs and capture hospital urinary catheter device days. Demographic data was also obtained, like age and gender, as well as clinical data, date of CODI, catheter insertion and removal dates, organisms isolated, and hospital unit at the time of CODI. Certified infection preventionists perform CODI surveillance through daily review of lab results to identify possible infections with supplemental chart review to determine whether the National Healthcare Safety Network criteria for symptomatic CODI were met. Additional data collected from this supplemental chart review included immunocompromised status, off-unit transport with catheter in place, patient location, and other chronic conditions. Data collected and existing measures. So of the patients who experienced CODI, most were female, 75% total. A median age of 10.3 years old at time of infection. Majority of patients were also receiving care in the pediatric ICU or the cardiac ICU. And 50% of patients had a recognized risk factor for CODI, including a genitourinary condition, an immunocompromising condition, and history of intermittent catheterization at home.
So why is this important? Studies found that hospitalized children with urinary catheters had a substantial risk of CODI before the intervention. Findings also suggested that female patients are more likely than male patients to acquire a CODI, and chronic conditions were prevalent among patients who developed a CODI. The study also noted that significant reduction in CODIs associated with multidisciplinary hospital-wide QI initiative that developed and implemented a pediatric CODI prevention bundle. Also, future work is needed to assess the capacity to implement a similar CODI prevention bundle in other pediatric settings and to determine whether implementation is consistently associated with reduced pediatric CODI.
Advantages of the study include the CHOP Prevent CODI team joining the Institute for Healthcare Improvements, CODI Prevention Collaborative, and developing their own CODI bundle. After implementation of the CODI Prevention Bundle, the mean monthly CODI rate was 2.49 infections per 1,000 catheter days versus 5.41 infections per 1,000 catheter days before implementation.
Some limitations include that they were unable to determine whether the interventions introduced caused the observed reduction in CODI rates, or if improvement was related to enhanced attention paid to the issue or other unmeasured factors. There can be significant variation in the application surveillance, definitions for CODI and other care-associated infections. The findings may not be generalizable to all pediatric settings. Data were potentially biased by the Hawthorne effect. They were unable to identify all potential barriers to full implementation. CODI prevention interventions were simultaneously introduced as a single bundle, so they were unable to determine the relative contribution of individual activities to CODI, and costs associated with this work were not captured. Some challenges include little is known about the ability of evidence-based bundles to prevent CODI in hospitalized children, and they did not note a marked reduction in device utilization with the implementation of a bundle. Some future recommendations include that the goal is to eliminate CAUTI in patient population by focusing on sustaining the improvements attained by this work in insertion and routine care of patients with urinary catheters, while expanding the components of maintenance bundles, and also to prevent diminished compliance with CAUTI prevention practices by continuing to feedback performance data from insertion checklist units, and also having leaders conduct point prevalence surveys to assess compliance with maintenance practices related to urinary catheters and other indwelling medical devices.
And these
These
are
are-
our references, and thank you for listening to our presentation.